now we're going to switch gears and welcome Dr. Hernan Gonorazky, who will speak more specifically about care for our pediatric patients. Dr. Gonorazky is a pediatric neurologist at Sick Kids and co-leads the NMD4C's work in developing a clinical research curriculum for neuromuscular fellowship programs. So thank goodness for you. Slides up here.
Thank you, everybody, and thanks so much for your invitation. And actually, I see some.
I pulled the microphone down for you.
I see some familiar faces here from our clinic. Thank you so much for the invitation. So I probably you're going to hear a little like repeats from what Charles has been saying, but one of the things that I think is important to understand the pediatric side on FSHD because the natural history is actually different, and probably you know that kids. Or if you actually have symptoms since you were a kid as well, you know that probably it's more severe. So understanding that component is actually extremely important. There are actually differences with the adult side as well, and we need to actually understand those gaps of knowledge, especially in the Canadian population. You compare with other dystrophies like Duchenne muscular dystrophies, for example. In our clinic, we follow around 110 patients with Duchenne. Compared with FSHD pediatric, who is around 17, 18 patients. So in terms of actually advocating for specific disorders, like having less amount of patients just for FSHD, it might be a little difficult. So I usually tell patients with FSHD that eventually I also discuss with other conditions as well to advocate actually for the all neuromuscular conditions in general. So what is infantile FSHD? So it's actually defined, presence of standing symptom facial weakness before 5 years of age, or the shoulder weakness before 10 years of age. Around 4% of the population is FSHD, it's actually the pediatric side. And then, as I mentioned, it's a more severe and rapidly progressive. And they tend to have actually systemic improvement. As actually Charles was mentioning, the hearing loss is one of the most common things that we see. And actually most, like around 50% of our patients was actually sent by the ENT specialist because of the hearing loss, and they actually saw that there was some facial weakness. They weren't sure of what's going on. They sent it to us, and we did a diagnosis of FSHD. And that's the story that we actually tend to see quite often. In terms of the early onset, we actually can notice sort of a bimodal component. One is actually more like around less than 5 years of age, or between 1 and 2 years of age, and then one after those 5 years of age, and the severity actually has a good correlation with that. So we actually see that patients that actually were in red because the early onsets have, of course, less repeats, more contraction of these D4, C4 that Hans, Dr. Lokinder were actually mentioning before. And those patients, especially the younger, really younger population, will actually have symptoms, more systemic symptoms, like, for example, the hearing component. The cold syndrome of the eyes is not super frequent to see it, but you can, but the hearing is the most obvious thing. In terms of disease progression, as mentioned before, it's actually highly clinical, it has a high clinical variability. We know with the large contractions that I mentioned, we will have actually a more progressive disorder. And what I want to show you is like this figure here, probably you have seen it before. These are the patients like in the first 2 decades of life. And they actually, in this nice paper, they actually check the 6-year risk of actually losing ambulation. And you can see that one of the first things, actually the early onset, there's around the risk of 20-24% of patients will actually lose ambulation in the first 2 days of life. And then that risk actually goes higher while with aging. So the two main parameters in terms of understanding loss of ambulation is one is actually the contraction, the D4, C4, with some variability there with the early presentation, and then eventually followed by age-related increase in the. So the same thing for the systemic component. As you can see here, the kiddos that actually have present less than 5 years of age, they actually have the hearing component, which is quite typical in our, again, in our own population. ENT actually has detected quite a few of those kiddos and send them to us, and it's actually quite common to actually see. They actually are mostly confused with other conditions like Moebius. I'm not sure if you have actually hear about it. It's basically also a congenital facial paralysis, sometimes with hearing component as well. So you need to do differential with those conditions as well. In terms of prevalence of complication by age of onset, I'm not sure how you see it there. What I want to show you is onset less than 5 years of age. This is bar over there. And you can see there's a significant higher risk for motor component or hearing impairment. And basically in general, there's a higher complication, higher risk, and higher severity. So if you think about this understanding eventually in clinical trials, like in general clinical trials, we actually will focus first in the adult population, and then we go to the pediatrics because it's the kids. You don't want to test anything in kids. You want to say check safety in the adult population. But eventually, in terms of efficacy, it might make sense to actually go also to the pediatric population since they are more severe, and eventually you want to do more for the kids, of course, like in general. But since the progression is actually faster, you might see an outcome faster. That's actually important. For example, in clinical trials, like in patients with SMA, which is another condition, spinal muscular atrophy, the initial was actually focusing more in the more severe side because eventually you see a difference, you see it faster. So that's something actually that we should consider. So Dr. Kasarjan actually talked about the distribution of weakness, and you know this, so I'm not going to go into too much details on that. This was discussed as well in terms of challenges of facial weakness, but it's actually important to understand as a parent when you actually see your kiddo. A lot of times we actually see that they are, oh, that's why they were not smiling in their birthday party. And it's like, that's why it's like, so it's really important to actually work with the social worker hospital and actually talk with the schools to basically make them understand all these kind of things. Because sometimes we actually got some of the teachers saying, oh, the kid's actually not expressive, it's actually like a timid, it's like that, because it's just the facial component. So actually explaining all these things to the school or the social environment that they're actually living is really important. Quality of life. Quality of life is actually something that it's really an individual concept, and it's important to understand that. And what we feel is like, maybe it's not loss of ambulation, like loss of ambulation, this kind of things, it might not reduce the quality of life. If you actually have a good insertion in the society, that actually improves the quality of life immensely. And that's where we actually need to take a look. In terms of the facial component, they are going to talk about it. From likely, there's a physical therapy, acupuncture, there's no evidence around that, or there's no strong evidence around that. Speech therapy and communication strategies is actually important, maybe not the in the verbal, and I'm eventually trying to find different techniques to actually express this. It's actually a nice paper that actually we published in terms of the facial component and expression. Surgical options, I don't think it's actually something that you would actually want to do in the FSHD population. It's just because muscle atrophy in general, different than other conditions. And important supporting psychosocial intervention, that's really important to actually discuss, especially if the kids actually getting understand what's the social component at school, as mentioned. So if you think about FSHD and the genetics, as Dr. Lockmiller was actually mentioning, like it's not exactly the same, but the effect that you're actually having, and I agree in terms of it's different than other completely different dystrophies, as someone in the back was actually mentioning. It's basically like a program apoptosis. Apoptosis is like the muscle is actually being programmed to actually die the cell. Okay, different than in other in Duchenne, for example, which is actually muscle fragility. So if you need to compare with something, maybe it's not so much with other dystrophies, which maybe I will compare with more with sarcopenia, which is this the muscles getting old, and everybody actually goes with sarcopenia. But this is actually way more in a way, with FSHD population. And actually that early involvement, as it was actually mentioned, will actually produce involvement in different muscles, as the asymmetry is a key component here. And as I mentioned as well before, sometimes you have plateauing and then there's a regression really fast. And that's related to the DAX4 expression is not constant all the time. It's like you have a burst of expression causing the damage and then it's shut down again. And that actually continues over time. What actually triggers it, I mean, trying to be an intermediate side, like if you actually do eccentric exercise, and this is what I think, like eccentric, that can produce muscle damage. If you have muscle damage, eventually you can actually have lack of recovery of the muscle. That doesn't mean that you shouldn't do exercise. The question is what kind of exercise you should actually do. And this is something the physiotherapist probably will talk. If you have asymmetric involvement, if you have a balance, thinking about this wobbling thing that you're discussing, if you have unbalance there, then that most likely, because of just purely biomechanics, will actually trigger a lot of pain. And pain is a key concept in the FSHD population and surgery. So how's the data in, like, what's the impact or the data that we actually have in exercise in pediatric populations? Like, we don't really know. We actually have assumptions, but there's not much studies around it. But it's important to understand that in dystrophies, like in Duchenne, you actually have muscle fragility. So if you actually do, for example, eccentric exercise, you might actually produce more muscle breakdown, and that's actually a problem. But in FSHD, what actually is happening is like a program death of the muscle cell in a way. So if you actually producing muscle damage, you might not recover it, but you can actually do some kind of exercise to actually try to maintain it. And I think it's like sarcopenia, probably you need to have a good intake of nutritional proteins, and eventually the kind of exercise. And usually the exercise I usually recommend is isometric exercise. I love planks, but of course you have different progressions on the planks. Most likely, we usually recommend the phase 1, phase 2, and the planks progression. And there's way more other exercises you actually can discuss, especially when you start feeling pain. It's actually this is about acting on the muscle component. So that's something you need to actually understand. I usually go to my clinics with my yoga mat. Some of the patients that here, they actually see that. Extraocular manifestation. I'm going to stay too much longer here. Usually cardiac muscles really work to see. High frequency pitching, hearing loss, something you see. However, we see the loss in the first 5 years of life. If we didn't detect it there, eventually it's rare to actually see later. I mean, you can have it. It's important to actually check it from time to time, but usually I'm more worried in the first 5 years of life. Sleep disorders, usually you can have it, but I mean, eventually, like later on in the pediatric population, the cultures, I haven't seen it. The respiratory component, you know, has been reported in way more severe cases, but it's not something common that you actually tend to see. So, in conclusion, you guys are the main advocates to actually understand the conditions in Canada, as not only at the Canadian level, but also in your local component, understanding the spectrum of what we can actually do. I agree with Dr. Charles Charles about what, like, you think that the hospital will actually provide everything. I can tell you there was no dedicated physiotherapist at Kids Hospital for neuromuscular conditions. And you say how that can be. It's like, well, it's actually, I still don't have a 1.0, which is full clinical, full physiotherapy for a full clinic. So advocating on the national level, but also local, is really important for you guys. Okay. So with that, thank you so much, and open for questions.
Yeah, we do have time for Dr. Gonorazky. A couple questions. Anyone? I knew Carrie would have a question.
I saw you like a month ago.
Yes.
When you say advocacy to get more physiotherapy in your clinic or interdisciplinary, what would we do or how can we do that?
So I think it's important to understand and to, at the end, and I'm sorry to say, but it's everything about money. and the hospital, and how much the organizations and the local communities actually are advocating for specific clinics. Just to treat it like, broad component, like oncological CPs is really strong because you have like a lot of family pushing for it. In neuromuscular, actually, we have families like the Asian associations and BC actually focus a lot, but like you should actually try to lobby within sick kids if you're going to the hospital sick kids or eventually your local communities. Like, what do you guys think is actually needed and what's actually lacking? And this is actually a conversation between the physicians, because I might have an idea, but you guys have a completely different idea of what's actually needed. You might say, oh, I have physiotherapists in the community, great. But you need to understand that you need to have actually physiotherapists also at the centers with expertise in FSHD. If you want to have clinical trials in that center, that understand the condition, to actually understand how these new interventions are actually doing things like that. Like clinical trials, for example, we run a lot of clinical trials in gene therapy. We have a lot of expertise with that, but those findings are actually coming from the clinical trials. The hospital doesn't put a cent, like a penny on that. So it's important you actually look into what's actually needed in your community to actually get things done.
Any more questions for Dr. Gonorazky?
Thank you so
All right,
much.
thank you.